Michael Gorin, I'm a urologist at Mount Sinai in New York, and I'm going to be talking about transperineal prostate biopsy. Because this is a CME event, some disclosures relevant to this talk. I serve as a consultant for Perineologic and Coelis, both make products I'll be speaking about. So transrectal prostate biopsy is the approach that all of us are most familiar with. One challenge with the transrectal approach to prostate biopsy is the fact that the biopsy needle traverses the rectal mucosa where it could pick up bacteria on its trajectory to the prostate. And because of that, there are significant complications associated with the transrectal approach to prostate biopsy. Most notably, what we're talking about are infectious complications. And in the systematic review from Michael Liss and coworkers, which was published in the Journal of Urology a few years ago, they reported an infectious complication rate as high as 5 to 7%. When we look at serious life-threatening complications, this could be in the range of 1 to 3%. And yes, it's true, over the years, these numbers have come down a bit. They still remain rather significant. So when we place that in the context of the fact that by one estimate, up to 1.97 million biopsies are performed in the United States alone, if we model out the risk of infections and sepsis, these are issues which affect tens of thousands of men each year in the United States, as well as Europe. So the American Urological Association has made some recommendations in 2017 for how to avoid infectious complications from prostate biopsy. Two of those pertain to transrectal prostate biopsy, and that's using an augmented antibiotic approach, which probably many of you use in your practice, where you're not just using ciprofloxacin, but instead you're adding to it a cephalosporin or aminoglycoside. Or alternatively, you could be performing rectal cultures where you take a swab of the man's rectum and then plate it on a quinolone impregnated plate to look to see if the antibiotic flora in the rectum is sensitive to Cipro or Levaquin. And with both of these approaches, the infectious complication rate has come down about tenfold in the last decade. An alternative approach, however, which is put forth by the American Urological Association, is to avoid the rectum altogether and to instead perform your prostate biopsies percutaneously with the transperineal approach. And the reason why this is so effective is pretty obvious. Rather than placing a needle through the rectal mucosa where you have stool, instead you're going through an area of skin which could be sterilized like we do for any other surgical procedure. And the infection control benefits seem to be, the infection avoidance benefits of the transperineal approach appear to be so great that at present, the European Association of Urology goes a bit further than the American Urological, and they actually recommend that transperineal prostate biopsy should be the first choice when considering whether to perform a prostate biopsy on patients. And I'll show you how they got to that point. So there have been a handful of randomized control trials comparing infectious complications of the transrectal versus transperineal approach to prostate biopsy. This is a meta-analysis that was published in the Journal of Urology 2 years ago, and they found about a 55% reduction in all grade complications. So everything from an UTI, which is managed with outpatient antibiotics, epididymitis, all the way through to sepsis, 50% reduction in infectious complications when you avoid the rectum. If we look at a study, this study here, which includes data from studies of mixed methodological design, data on 163,000 patients who underwent a transrectal or transperineal prostate biopsy, they found a tenfold reduction in the risk of sepsis comparing the transrectal to the transperineal prostate biopsy approaches. Because the risk of sepsis is so incredibly low with the transperineal approach, folks have advocated for doing this procedure without any periprocedural antibiotics whatsoever. I personally, when I started performing the transperineal prostate biopsy 6 or 7 years ago, I never gave patients antibiotics, but now finally, as of last year, we have level 1 evidence to support this practice. This is what's known as the NORAP trial, where patients were randomized to antibiotic prophylaxis or no prophylaxis prior to receiving a transperineal prostate biopsy, and there was absolutely no difference in the rates of sepsis, with 0 sepsis events in each group and only 1 UTI in each group. And this was published in Lancet Infectious Diseases. You wouldn't dream of performing a transrectal prostate biopsy without antibiotics or, even without augmented antibiotics. But transperineal, we could do it with very low complication rates. And this isn't just good from the standpoint of being able to avoid the use of antibiotics, maybe because they're expensive, because it's administratively a hassle and so forth. This is good overall medical practice in terms of antibiotic stewardship. We all know that there are increasing rates of antibiotic-resistant organisms, these fluoroquinolone-resistant bugs, ones that are now resistant to carbapenems and so forth. And by avoiding the use of antibiotics, we place less selective pressure on these organisms and really do our part with antibiotic stewardship. So hopefully now I've convinced you that the transperineal approach confers a better risk profile with respect to infectious complications. There's also evidence to show that the transperineal approach leads to improved prostate cancer detection rates. This is a study by Schouten and coworkers, which was published in European Urology in 2017, where they took patients who underwent an MRI-targeted transrectal prostate biopsy with systematic sampling, and they looked to see how often were cancers detected in the anterior versus the posterior aspect of the prostate. And then if they omitted the if they omitted the targeted biopsy, how often would those systematic biopsies have missed anteriorly located tumors? And it turns out that about 40% of all prostate cancers are located in the anterior aspect of the gland. However, when we look at the subset of tumors that were missed, over about 80% of them were anteriorly located. And if we had a better approach for detecting anterior tumors, then this proportion would come down considerably and probably be more reflective of the overall distribution of prostate cancer in general in the gland. It's not only, though, because of systematic sampling of the prostate. This is a figure that I made and posted to Twitter one day when we were sort of arguing back and forth about the benefits of transperineal versus transrectal. For me, the real benefit to the transperineal approach to prostate biopsy is because your biopsy cores, they enter the prostate in such a way where 100% of the tissue of captured by the core is found in the peripheral zone of the prostate, where we know 85 to 90% of prostate cancer is found. However, when you go transrectally, in particular with your more medially located cores, anywhere from, I'd say, 50 to 90% of your core could be wasted in the posterior transition zone of the prostate, where we infrequently find prostate cancer. So simply put, the sampling density for the peripheral zone is considerably higher with transperineal than transrectal. And there is data to show that the transperineal approach is superior to the transrectal approach for detecting prostate cancer. This is a study by Yarber in Israel, published in Prostate Cancer and Prostatic Diseases. Patients underwent both an MRI transrectal targeted biopsy and MRI guided transperineal prostate biopsy in the same setting in the operating room, and they found a 15% improvement in the hit rate when the transperineal approach was employed. This is probably the strongest evidence to date that's been published, and this comes from Pepe, published in Clinical Genitourinary Cancer in 2017, where they took 200 men who underwent a prior prostate biopsy, and it was found to be negative. Yet they had a persistent or rising PSA, and they subjected these patients to a saturation biopsy, basically like a needle prostatectomy in the operating room. They then performed MRI-guided transrectal prostate biopsy and MRI-guided cognitively performed transperineal prostate biopsy, and then we're able to compare the sensitivity and specificity of those two biopsy strategies relative to the truth standard of the saturation biopsy. And what they found is that the overall sensitivity was significantly higher with transperineal versus transrectal by about 30%. Importantly, when you looked at anteriorly located tumors, the sensitivity of the transrectal approach was only 25%, but it was 94% with the transperineal approach. And due to limitations on time, I won't take you through all the data here, but if you're looking for some evidence that supports the transperineal approach, this is among one of the best papers, and you can see with almost all these parameters, transperineal outperformed transrectal. This is data from a large retrospective study from 10 centers throughout the world, Europe, China, Australia, and so forth. A paper written by the Young Urologist section of the European Association of Urology, where they found a 20% improvement in the detection of clinically significant prostate cancer with the transperineal approach, albeit the limitations of a retrospective study. These are data from when I was formerly at Johns Hopkins. Bal Carter had just retired. He was previously performing transrectal MRI-guided prostate biopsies. When I took over, I started performing transperineal prostate biopsies. So we had an interrupted time series experiment where we could compare my upgrading rate among the active surveillance patients at Hopkins to his upgrading rate. And lo and behold, once we introduced transperineal prostate biopsy, even after controlling for known covariants, the reclassification rate went up by 46% just by implementing the transperineal approach. And we also looked at specifically by PIRADS lesion, and we found that the benefits for the transperineal approach were greatest for PIRADS 3 and PIRADS 4 lesions. And this is because these lesions are less conspicuous, harder to get to. And once you have transperineal, and you can take advantage of the approach of that biopsy, you all of a sudden have a higher hit rate with that approach. Perhaps this isn't enough data to convince you of the transperineal approach. If it's not, we await the results of at least 2 randomized controlled trials. One is the PRO-B prostate cancer study, and the other is the Translate study being led by Freddie Hamdy in the UK, and we'll have those data soon. So very quickly, there's a handful of methods for performing transperineal prostate biopsy, and at the hands-on sessions, we're going to talk a lot about these different techniques. There were the original, what I call the OG, the original gangster approaches. There was the open biopsy that Hugh Hampton Young did in the 1920s. For obvious reasons, this went out of favor. We started performing finger-guided approaches in the 50s and then evolved to transrectal prostate biopsy once ultrasound became available in the 80s. However, it was very quickly realized of the infectious complications of transrectal prostate biopsy, and folks like Dr. Stone in the, I guess it was early 90s, Dr. Stone, when you first started investigating this type of stuff, the brachytherapy grid stepper unit came into play to perform transperineal prostate biopsies under ultrasound guidance. One of the challenges, though, with this approach is that you could only move your needle in 2 planes, right? You could go up in X and, up in X and across in Y. You can't, actually orthogonally or obliquely guide your needle. And so because of that, you're sort of stuck when you hit a rigid structure. The other issue is that you're limited to perform these types of biopsies under general or spinal anesthesia because the grid plate takes up so much area of skin. Right now, prostate biopsies, over 90% of them are performed in the outpatient office setting here in the United States. If we were to make this change to the transperineal approach with a grid stepper, we would, basically inundate our ORs and be unable to perform any other form of urologic surgery. So because of that, folks had to develop a better way. And again, this is the concept of pelvic arch interference, the fact that you could only go up, down, left, and right with your needle. And once you hit the pubic arch, you're sort of stuck. And a significant amount of prostate could be missed based on that pubic arch interference. So folks then evolved to perform what we call the freehand-based technique for prostate biopsy. Freehand for a few different reasons. Number one, the ultrasound probe is no longer held on a grid stepper. It's held in the urologist's hand. And the biopsy needle is free-handed, independent of a grid through the skin. And in this original description of the technique, angiocatheters were placed on either side of the perineum so that you only had to numb a very small area of skin. You could then put your access cannula through it and then put your biopsy needle in and out of this one spot, making it tolerable under local anesthesia. And also because you had this fulcrum, this point where you could sort of navigate from, now you could orthogonally place your needle in all areas of the prostate and avoid the pubic arch. The problem, though, is that this needle isn't tethered to the ultrasound probe, and it really takes, a master to be able to do this. So folks have come up with a variety of different needle guides that now tether the biopsy needle to the ultrasound probe. I won't belabor the point here, but suffice it to say that your ability to hit targets and to get through this procedure in a reasonable period of time goes up exponentially once you start using a needle guide. And folks, when they're asked would they rather do it with a needle guide, they universally, of course, say that they agree. In my view, and again, consulted for this company, the best device for performing transperineal prostate biopsies with the freehand-based approach is what's known as the Precision Point Transperineal Access System, which was invented by my former partner in practice, Dr. Matt Alloway in Cumberland, Maryland. It includes that single access cannula that goes into the perineal skin that allows you to go in and out with your needle multiple times, but importantly tethers the needle to the ultrasound ultrasound probe so it stays in plane with the transducers. And this is just some images of me using the device. And you could see just how amazingly in plane this needle is. You could see it for its entire length, over 6-7 centimeters. You could even see sort of the inside of the cannula here. I mean, it's like perfectly in plane when you do this. The National Institutes for Health and Care Excellence, NICE in the UK, actually recommends the precision point device as the preferred technique for performing transperineal prostate biopsy. There are some acceptable alternatives, but there's less evidence for them. Among those alternatives is the Perrine grid, which is manufactured by Coelis, which is one of the sponsors of the meeting here today, and we'll have a chance in the hands-on sections to